I'd like to thank Dr. Meron Pitcher for being here. Meron is a breast surgeon at Western Health and a general surgeon. Meron has worked as a specialist at Western Health since 1993. Her training was in Melbourne and subsequently in London at the Royal Marsden Hospital. She's been a senior examiner in general surgery for the Royal Australian College of Surgeons. At Western Health, she's the head of breast unit and the head of the Sunshine Hospital General Surgery Unit, and has some responsibility for quality and safety in perioperative services. Her research interests include improving quality of care for breast cancer survivors. Hand it over to you.
Angela, thank you very much for that introduction, and thank you for inviting me here today. Clearly, everyone's here because they want to improve their practices in screening for cancers in general. So I'm really glad you've had time for a cup of tea and something to eat, because I think the sort of after lunch session's pretty deadly, really. So my topic is to talk to you about screening for breast cancer, and my real focus is in terms of the Breast Screen program, which is the government-funded program for screening for cancer. So the data out of Cancer Council says that in 2017, which is the latest data we have available, there were 4,500 cases of breast cancer and just under 800 deaths. And so what that says is there's a lot of breast cancer out there, and thankfully the majority don't die of it. I didn't do very well with my cut and paste here, but the purpose of this graph is, again, the data from 2017. On this axis, it's the rate per 100,000 patients on the y-axis, and on the x-axis is in the age. And so you can see basically there's no one under age 24 in 2017. There's a tiny starting in early 20s, but really the peak age of rate of diagnosis of breast screen is in women late 60s and age 70. And so it increases substantially once women get into their 40s, but particularly after the age of 50. So despite what you might think in terms of watching soap operas or various TV news, breast cancer, like most cancers, is a disease of ageing, but it does occur at younger ages. So what are the risk factors for breast cancer? Being a female, I didn't put that up. The older we get, family history. I get confronted by advertisements. Do you know your breast density? I mean, it's a load of complete nonsense, but people with really dense breasts do have an increased risk of breast cancer, and I'll come to that a little bit later. Obesity, substantial risk for breast cancer, particularly postmenopausal, and sadly, alcohol in any dose is a risk factor, but it is dose dependent. So the sort of bits in family history that are particularly significant for breast cancer is really the number of first and or second degree relatives with breast or ovarian cancer. So first degree relative, mother, sister, daughter. Second degree relative, grandmother, aunt, niece. I generally ask my patients, is there any family history of breast cancer, anyone in the family who's had breast cancer or ovarian cancer? And because breast cancer is such a common disease, most of us have got someone in the family with breast cancer. Like, oh, great Aunt Ethel had breast cancer at age 72. Well, that's very sad for great Aunt Ethel, but it probably doesn't have very much implication for that 30-year-old who's worried about breast cancer. So first degree relatives are the most important, second degree relatives less so. And the other important bit is what age were these relatives when they were diagnosed? So particularly age under 40, that to me is a bit of a red flag. There's some data that if your mother, and that's the only relative with breast cancer, was diagnosed after the age of 55, so you've got a mum diagnosed at 55 or 56, statistically your rate of breast cancer is the same as the community. So that is, that doesn't mean to say that woman or you aren't more concerned because of it, because you've seen what's happened to that relative and it may well be more pertinent to you, but statistically, you're not actually in a particularly high-risk group. Bilateral breast cancer is a warning sign. Any male breast cancer in the family is a substantial warning sign. The Ashkenazi Jews have a particular founder mutation. So if you've got someone with a Jewish heritage, particularly Ashkenazi, then that is of significance. And clearly if you've got someone who's the sister of, or even perhaps cousin of, someone with a proven genetic mutation, that's going to be significant. There are 2 online tools that are helpful if you have the time and the appropriate consultation. This is a long consultation. You should charge for a long consultation if you have, I think you have ways and means of doing sort of extra consultations if you're going to do this. The top one is, that stands for Familial Risk Assessment, Breast and Ovarian Cancer Online Risk Assessment Tool. You'll find it, you can put that into Google and you'll get it. It comes up on Cancer Australia, and in that it's sort of a little survey that says, okay, who in the family has had breast cancer or ovarian cancer and at what age? And it will give a calculation. So that's a really helpful one that you can do online, anywhere, anytime. Peter Mack, through Kellyanne Phillips, if any of you know Kellyanne, have put together this, again, another online risk assessment tool called iPrevent. And now, when I put in iPrevent to try and find it for you, it went somewhere else. So you needed to put Peter Mack and iPrevent as well. But in essence, again, this is a bit of an annoying tool because they really want the good thing, but there's some good things about it, so it's worth it. It says, you know, what's the age of the woman who's there with you? What's her history of breast disease? In other words, has she had previous breast biopsies or previous diagnoses? Age of menarche, I think, is on it. Her weight, her height, so that BMI is measured, and then the family history. And it wants you to put in every second-degree relative. So if they come from a family with 7 uncles, they really want you to say, what was, you know, Uncle Fred, how old's Uncle Fred now, what age was Uncle Fred when he had this, that or the other thing. So the way Peter Mack have started to do it is to give the patient the online tool and get them to fill in all the family history, because my attention span gets lost after about 2 relatives. So it's really, you know, it's fine if they've got sort of mum and grandma and auntie so-and-so, and what age was it, and was there any ovarian? It's quite detailed, so it probably takes, I've done this with some of my patients who are particularly anxious and want to know what's what, probably takes a good 20 minutes to go through, but at the end it says this person's risk of breast cancer is X% in the next 10 years. And it says if she, you know, and puts it into a high risk group or a medium risk group or an average risk group. And then it says what are the things that can be modified. So that for the lower risk end, they're going to talk about getting to ideal weight, doing exercise, minimising alcohol. And if you do those, what does your risk go down to? Likewise, if you take tamoxifen or one of those as a risk reducer, you will reduce your risk by X%. So it's really helpful in that space, but I suspect for the majority of you in general practice, you probably haven't got the time and the wherewithal. But if you've got a family where you really want to spend some time, or this person's really keen in terms of where you're going, as a online risk assessment tool, both of those can be helpful, because it's pretty easy. You get in on the internet and just plug the data in. But it's the sort of thing that's worth having a play with yourself, just to see. But you know, you need time to do it, and you know, it's. But I think they're good and they're clear. Alcohol increases your risk of breast, but also many other cancers. Obesity is said, if you've got a BMI of over 25, the increase in risk is 20 to 40%. That's a lot. Again, we know that obesity is a risk factor for many cancers. And so I would take every opportunity to encourage your patients to think about their weight. And I'm sure you all have ways and means of doing that. My current way is to say, you know, weight is an issue. Losing weight is really, really hard. The important thing is to not put it on. So please stop putting weight on. To me, that seems a bit less confrontational, saying you're too fat, you've got to lose weight, which I don't think works. But certainly obesity is particularly true of estrogen-positive breast cancers, and that's particularly true in postmenopausal because fat does some of the aromatization. So people who are fat are more estrogenized. And we know that's true of sort of endometrial cancer, those things as well. Breast density. This is a mammographic assessment. It's the way you're made. If you're on hormone replacement in your 70s, you'll have dense breasts, right? But if you're premenopausal, about half of us, I'm sorry, not premenopausal anymore, will have dense breasts. Age is a much stronger factor than density. But you will see that there's various advertising out there, know your density, which to me says, well, what am I going to do about it? All right? Apart from perhaps have 5 kids before you're 25, and that's not going to work for everybody. You know, a part of it, warning, cynical, very cynical. Part of this is radiology industry going, you could have a breast MRI and that will cost you $600. Thank you very much. And we might find something we don't know what to do with. Excellent, we've got to repeat it. So to me, just be aware of the breast density fabric, okay? What I think we're here to try to do is to talk about population screening. Really, the average person who comes in wanting their flu vax, the sort of opportunity to talk about where are you at with your cancer screening. So to me, I'm going to run through a little bit of the evidence. I want to really highlight that screening for cancer is about people with no symptoms or signs. And a bit like Chris said before, if someone comes in with rectal bleeding and a change in the bowel habit, you've got to examine that person for bowel cancer. You've got to do a rectal examination. The person's going to need a sigmoidoscopy, colonoscopy, what have you, if they've got change in symptoms. Likewise, if a woman says, I think I've got a lump, or I have got a lump, they shouldn't go to breast screen. They should go and have a mammogram and an ultrasound, or whatever it is in terms of age-related. So to me, my focus is on screening. If you're talking about the population, it's for people with no symptoms. If they've got symptoms, you go down the diagnostic pathway, not into a screening program. Breast screen started in Victoria as a pilot in 1992, so it's been going for 25 years, a little bit longer. I've got some information from their annual reports about what their outcomes are and a little bit about what happens at breast screen. So the evidence goes back to basically the late 1980s. The first trials for screening were done in the 1960s. So the data is old and there were many trials. There were about 5 or 6 trials that all published in the late 1980s, looking at those people who'd been screened in the 60s and 70s, which demonstrated a survival advantage. And that's why in the early 1990s around the world, mammographic screening programs took off. And the reported mortality reduction in those which were reported late 80s, early 90s was about 30% in women aged 50 to 69. And they were having mammograms every 2 years, which is what we recommend, and they were doing 2 views. So they were doing craniocaudal from above, mediolateral oblique from the side. So that has been the standard screening that's really been happening since the early 90s. There have been some modifications and we can talk about that. There remains a lot of controversy around the benefits of screening. And those who are strong advocates, and indeed the data of those who turn up for screening, is that maybe there may be a 50% reduction in mortality. But we all know that there are certain groups of people who will turn up for screening and there are certain groups of people who don't turn up for screening. And you've taken me back to a happy place of when I was a junior registrar and my boss, one of my mentors, Ken Miller, sadly went to God a couple of years ago, but Ken would say, screening is for the willing, the worried and the wealthy. And I think he was right. Now, we're trying to actually improve the unwilling in that space, and by and large the government is funding to reduce the need to be wealthy. But there is a significant selection bias in most of the screening studies. So what is the evidence? So Breast Screen Australia, they might have a conflict of interest in terms of what the screening should be, indicated a reduction in breast cancer mortality in this target age group, 50-69, of between, if we said between 20 and 30%, and the current participation rate around the country is about 56%. So it's still low. The data that I remember is that really to make a significant difference you need to get 70% screened, but 56%'s not that bad. And participating in the breast screening program, and as you probably know, the recruitment age has gone up to 74 in the last 10 years. The expectation is that if 1,000 women turn up every 2 years between 50 and 74, 8 deaths will be prevented. So it's a fair number of screens to get 8 deaths prevented, but you know, if it's you and it's your sister or your mum, then that's pretty significant. So I think there is good data that screening reduces mortality. But like anything, screening doesn't detect all cancers. Some women who are screened will still die of their cancers, and we have the issue of overdiagnosis, which I'll come to in a moment. These are the latest statistics published by Breast Screen Victoria, and they did 260,000 mammograms. And of those, nearly 12,000 got recalled for assessment. And of that, 1,767 cancers were diagnosed, 1,400 invasive, 360 odd ductal carcinoma in situ, so precancer. So if you remember back to my second slide, something like 4,500 people diagnosed with breast cancer in Victoria. Not quite half of them, perhaps about a third of them, are being diagnosed through the screening program. And that's probably one of the reasons why the incidence of breast cancer has gone up, because we're diagnosing more of it. So to me, this is something I hope you can remember. I'll tell you the bit you have to remember in a minute. For women turning up for their first screen, and I'm sorry I missed the bit about your cervical screening talk, because I suspect in women being screened for cervical abnormalities, the first time there may be more issues. But people from having their first mammogram was about 14% of the total, so 35,000, and 11% of that group got recalled. So to me, when a woman is going to have her first mammogram, it's really helpful to warn them that 1 in 10 will get a recall letter to come in and have some further views or an ultrasound. Because people, they want to be screened to be told there's nothing wrong. You don't want to find anything, really. And then ultimately, if you do find something, you can go, well, actually, it was good that it was found early. But ultimately, you don't want to find anything. And many people are very distressed by getting a phone call saying, you've got to come in to Parkville and do this because we've found something on your x-ray. You know, that's a very stressful time. So it's helpful to say, for the first mammogram, it's not uncommon that you might get a call back because they haven't got anything to compare. They're the younger age, so they may well have denser breasts, they've got overlapping shadows, they've got cysts and things that'll be seen. So again, in that group, so about 10% of the first rounders get called back, and about 10% of those turn out to be cancer. So there's a pretty, to me that's a substantial minority that get called back, but only about 10% are actually going to turn out to have cancer. Whereas if you look at the people who are coming for second or subsequent screens, which is the majority, it's a 4% recall rate. It's a much smaller recall rate. So if they call you back after your third or fourth screen, you should be starting to be a bit concerned. And of those, nearly 20% turn out to have a cancer. So if someone gets recalled after a subsequent screen, it's more risky. Does that make sense? So to me, I think that's really important for first screen, which I think is what your tasks are in this program. It's really to get people to go for the first time so they can realise it's actually not too bad and not too scary. But so in doing that, warning them. They may find something. It probably won't be cancer, but you might freak out about it. So what's the process? To me, for breast screen, they will accept women over the age of 40. That's because Bob Hawke said women over 40 can have mammograms. Is there any evidence that screening women over 40 reduces mortality? No. Problem with being 40 or younger, denser breasts, more overlapping shadows, higher recall rate. That's not a reason if someone who's 40 or 43 wants to go. I would say to women who come and see me with a problem, I say, you should have your mammograms from age 50. If you're 40-something and your best friend gets breast cancer and you're worried about it, go to breast screen. That's what you do. But from a point of view of, dare I say, harassing women to get screened, I wouldn't be doing it in the 40-year-olds. Again, reinforce. This is for breast screen, is for women with no particular symptoms. Sore breast doesn't count as a symptom because all premenopausal women are going to get sore breasts at some particular time. They don't need a referral, though I think if you encourage them, that's probably going to be more positive. If you ring breast screen, they'll say, are you over 40? Yes. Do you have any current problem in your breast? No. Have you had a mammogram in the last 12 months? And if the answer to that's no, then they'll book an appointment. So to me, it's helpful that they don't have to get a referral to have it done. But that's the process. And it's 13, 20, 50. Sorry? You got it in the packs? Okay. So women from age 50 are actively recruited, I think through the electoral roll, and are routinely recalled every 2 years. They now, when you turn up to breast screen, you've got to fill out your name and all those sorts of things and put in your family history. And there was, I dare say some of you have seen some of the fallout from that because you get women in their late 60s who said, you know, Mum and Auntie Frida had breast cancer. Oh, you must be at terribly high risk. You must go and see your doctor about this. I think people go to the doctor to be made to feel better, not worse. But they've actually toned that down a little bit. But what they're trying to do is really people who do have a substantial history that they're getting appropriately imaged rather than on a 2-yearly basis. And perhaps if someone's getting one of those high-risk letters from breast screen, to me, that might be where you go in one of those online tools to actually work out where they're at. The good news is that women who've had their breast cancer treated 5 or more years ago can enrol in breast screen and get recalled annually. The advantage is breast screen are fabulous at picking up the most little tiny things. So in terms of their detection rates, their accreditation means they've got to be very obsessional about it. The patient gets a recall and they're not getting charged an obscene amount of money from various radiology companies. I do have friends who are radiologists, believe me. So the question is, what about the 40 to 50? The incidence of breast cancer is lower. They've got denser breasts, and they've got a higher recall rate, so far more chance of false positives. So as I said, if someone wants to go, very happy for them to do it, so long as they understand that higher recall rate. Warning, Meron only quoting from papers which confirms her prejudice. In the Nurses' Health study, which came out ages ago, which was one which had stuff around HRT postmenopausal, they looked at mammograms as part of that, and they looked at women in the States who'd had a mammogram every 12 or 18 months in their 40s, which of course you can imagine America being the land of the rich and free were encouraging. They found that in that cohort of women who were having mammograms between 40 and 50, 1 in 2 got recalled for further assessment in that 10-year block. And a percentage of those were so distressed by the experience, they never went back. So don't underestimate the negative effect of a recall. Now, it's fine if they just take an extra picture and they go, you're fine, don't worry. But if they go, it's probably all right, we're not sure, we need to do a biopsy, and then they have trouble getting the biopsy and it's not very nice and all of that, you can understand people go, why would I go there? You know, they're relieved that it's not cancer. But to me, again, warning, that is my prejudice telling that, but just be aware of that controversy in that. Maybe it's not controversy, but it's just the effect in that younger age group. What about the over 75s? I saw a letter from Breast Screen today of a patient who's been coming to see me for 20 years. She's now 82 and she's just gone to Breast Screen and had a clear mammogram. And I don't know, I think her sister might have had breast cancer at 65. But Alva, that's her name, she's a really classic 82-year-old, retired teacher, somewhat overweight, completely normal breasts, never had any problem. I think I inherited her from George Toms, gynaecologist. Some of you remember the lovely George. And she wants to come and see me every year to have her breasts checked. That's very nice. I sort of have been encouraging her not to, but I've given up having arguments with her. But to me, I like having arguments, but it's not worth it. But to me, what I would say is, what is the purpose of breast screen? And you can argue this for bowel screening or cervical screening. We're trying to find something at the earliest possible stage so that we can treat it so it's not going to cause trouble in that person's lifetime. So what I say to people in their later 70s, and certainly 80 and over, I said, do we want to find something that is unlikely to cause, if it's going to cause problems, it'll probably be in the next 10 years' time. Because the majority of 80-year-olds don't really want to undergo unpleasant biopsy, inappropriate operation, radiation, tablets, over and above what they're already on. And I would say if they've got a lump or they've got a problem, of course we do a mammogram, of course we treat them. But do I want to find a low-grade cancer that is not going to affect their life quality and life expectancy? And so to me, my cut-off is 80. I don't think 80-year-olds should be doing screening, probably for anything. I think most people up to 75 are pretty good, and somewhere between 75 and 80 it changes. And certainly in my career, and indeed in some of your careers, you'll see all these people you thought would have been dead years ago. They're still alive with their cardiac stents and their renal replacement therapy and all things. My ability to prognosticate is now dreadful. So people are living longer and getting things. But, to me, what are we doing diagnosing pre-cancer in a 77-year-old? It's cruel and it's expensive and as I think Chris said, emotionally it's crippling for some people. So breast screen, I've gone through that. All x-rays are read by 2 readers. They get a result in 10 to 14 days, and then, if necessary, they're recalled for an assessment centre. Our local one from here is Parkville in the old Mount Royal Hospital. So what are the controversies? Because of course there are controversies over diagnosis, and that is diagnosing something which would never cause symptoms in a woman's lifetime. And interestingly, the data of this, again, there are reams and reams of papers that have been written about it, is that if you take 1,000 women who have a 2-yearly screen aged 50 to 74, we spoke about that before, we said 8 women out of 1,000 would have their lives saved. But another 8 cancers may be found and treated that would not have been found in a woman's lifetime. So we're labelling people with cancer, putting them through some pretty unpleasant treatments, but we're also saving lives. So again, you can see that's a pretty big range. You know, if we're actually damaging 21 people, that's quite a lot. So the real difficulty is, if you find someone who's got a bit of precancer or a bit of low-grade invasive cancer, with giving that, if we'd waited until that low-grade cancer formed a lump and then we gave them some endocrine therapy when they're 77 because they're already on apixaban for their AF and they've got pulmonary hypertension and a few other things, we would still have, they still wouldn't have died of their cancer and it still wouldn't have turned out into a fungating horrible mess. But we've put them through that. So to me, the question is, you've found something, what do you do with it now? It's a bit hard to leave it alone. And most people, once you've found cancer, in inverted commas, be it precancer or otherwise, they want it out, which is entirely appropriate. But can I put my hand on my heart and say, I've saved your life? No. Ultimately, there are some trials happening which are open in the States for precancer, for observation alone. There's some data that I saw presented at our college meeting in Bangkok a few weeks ago which says for the over 70s, if they've got low-grade precancer and they survey them, their survival is exactly the same in the over 70s. If you're 40 and you've got something, then probably you should do something about it. 50 to 70, you should probably do something about it, but over 70, probably not much point. But I think there'll be, in the next generation, there'll be biological ways of working out this is a non-significant precancer, this is a significant one, I hope. Implants, that's always a controversy. You know, what do you do? I've got implants, I don't want my breast squashed, it'll hurt, it'll break the implant. The implants get pushed back so that they get a better view. Sometimes they need a bit more time for to take extra images. Sometimes a bit more radiation is required, and there is a small risk of damage to the implant, or more usually the capsule if they've got a hard capsule around the implant. But the risk of damage is really very small. I'm not having it because it's radiation. I don't really understand millisieverts and I don't expect you to know or remember any of this, but the point of what I've put up there is that getting 2 views, that's 4 images, is about 1/3 of the background radiation for the year. With tomograms, which is where basically the bosom is squashed but they take a continuous stream, a bit like sort of a CAT scan so to speak, there's a slightly bigger dose. The advantage of tomography is that it can reduce the risk for recall because it can eliminate some of the overlapping shadows, so you'll see a bit of that. But the amount of radiation is similar to an X-ray of the hip or a CT of the head, and the risk of inducing a cancer on a mammogram is perilously low. But yes, there is radiation. So this is my take-home message. Remember that screening is for people with no symptoms. If they've got symptoms, they need to go down the diagnostic pathway. I should have put up there, warn people that particularly the younger age group or first screen, they might get recalled. So don't jump off the Westgate Bridge if that happens. I would encourage you to encourage those women in the target group, that is 50 to 75. I have put the chance of recall, that was smart. Explain that they may get recalled and go through that process.